Good evening and welcome. I'm going to present now the new session, Breaking the Silence, Intimacy Living with Systemic Sclerosis. I first introduced the first speaker, Dr. Anne Schouffoer. She's a consultant rheumatology in the Haga Teaching Hospital in The Hague and Leiden University Medical Center. In the past years, she chaired the working group that published 2025 Dutch Systemic Sclerosis Guidelines. She's the medical advisor for the Scleroderma Brain Foundation, which aims to raise awareness of scleroderma and to initiate conversation about the condition. Anne has a special interest in patients' education and management of gastrointestinal symptoms and dryness in systemic sclerosis. Please, Anne, if you will.
Hi, everyone. Thank you so much for organizing this session, dear Vesca. And we're going to start with a question. Have you ever addressed the topic of intimacy and sexuality with your rheumatologist? And we do hope that you are able to scan with your telephone the QR code. It's a good starting point. I can't see how many people are responding, I think.
Oh, you're looking there.
Where are you looking? You'll get a quick neck if you do that.
Okay.
I will wait a little bit. Well, looks like the majority hasn't. Can you raise your hands if you're still busy? Yeah, okay, let's wait a little bit more. Yes. Shall I proceed? Yeah. What is the largest barrier for you which might prevent you from doing this? I don't feel comfortable or I feel ashamed. It does not impact or affect me. I do not think the rheumatologist is the right person for the topic or any other reason. You're still busy? Okay, I think we will proceed. And so this is already very informative. Thank you so much for your answers. This is sort of the background for the presentations that we're going to give. We prepared these together. And I'll be starting off with the clinical aspects and then the patient's perspective and reproductive issues in systemic sclerosis is presented by Maria Grazia. And Cosimo is going to talk about men and, of course, the patient's perspective after that. So my name is Anne Schouffoer, and I think why this matters so much is that there's a high, I have to put on my glasses to see it actually, high rates of symptoms, and especially the dryness, and I think the communication with health professionals does need improvement. And so what we're hoping for today is to give you background information on a delicate subject, but also to create a safe place to perhaps share experiences and tips. And I think the main focus for me is the communication. So let's together enhance awareness on the subject of intimacy and well-being. And I started off this presentation looking for ways to address this. And I came upon this study, which was really wonderful in a way I'm so sorry. Looking for a way to capture the impact of the systemic sclerosis on intimacy. And this paper has found words for the emotions and the consequences of their disease in depth interviews. And the interviewed persons that this paper concerned had inflammatory bowel disease. However, I think the impact of their condition on intimacy may very well resemble persons with systemic sclerosis. And so in this study, 4 domains were defined, and you can read with me. There's the interrupted connectedness with loss of spontaneity in relationships, like embarrassment, guilt, or not being able to be the partner that you want. There's loss of freedom with avoidance behavior, difficulty to disclose symptoms to potential partners, and even giving up on new romantic relationships. There's missing out on fullness with the loss of future prospects with emotions like anger, sadness, and loss of opportunities, and striving for normality. And there's, of course, loss of privacy, and it's something they call the otherness of the sick body, with mainly control over bodily function, medicalization, and even altered body image. And there's a lot of factors that are of influence on intimacy and sexuality in systemic sclerosis. And I do think that this is not a complete figure, but we can highlight some of the things, and you can add, of course. There's the Zika syndrome with the dryness, which is really irritating. There's the skin fibrosis with itch and pain, contractures. There's lung symptoms with shortness of breath. There's the musculoskeletal challenges with the range of motion, hormonal influences. There's the Raynaud's phenomenon with impaired hand function, and gastrointestinal symptoms like reflux that are really a barrier in sexual contact. There's, of course, the energy, the mouth symptoms, which are relevant, pain, the genital symptoms, and the altered body image, self-esteem. And with all the things that are impacted, mental health issues are also important. And so one of the questions that we wanted to address was the dryness and the mechanism of Zika, and how does it differ from the Sjogren's disease. And I think you can sort of see in these figures a sort of schematic figure with the overactive connective tissue cells, the fibroblasts that are surrounding a saliva gland in systemic sclerosis with excess of collagen. And in Sjogren's disease, on the other hand, there's the clusters of immune cells, the lymphocytes, and they really lead to the destruction of the glands. And of course, there's an antibody difference. And I think it's worthwhile mentioning that the overlap diseases, so if you have systemic sclerosis with Sjogren's disease, there's an association with a limited subtype and the anti-centromere antibodies. And these people tend to have more objective Zika syndromes, but also more fibrosis in the glands. So what are the non-pharmacological advices for the oral and the eye Zika syndromes? The dryness is mainly combated with hydration, of course, avoidance of tobacco, caffeine, and alcohol, and sips of water. The saliva can be stimulated with chewing, and you should, of course, use the sugar-free gum. And humidifiers are important, and choose the right moist foods. And of course, the oral hygiene is very important with fluoride toothpaste, and the regular checkups are, of course, very important. Well, for the eyes, we have the eye drops, but also the warm eye compresses. you should apply screen breaks, and you should, of course, pay attention to the proper eyelid hygiene and protection. And ophthalmologists usually use the topical immunosuppressants or even bandage lenses like the scleral lenses and autolog serum drops. And you can use also these glasses with the protection. And pharmacological options are the topical aids and the saliva substitutes for the mouth. And there's also the saliva stimulants. And you could also argue for the usage of these stimulants if the glands are still producing saliva. So if there's reversibility. And in case of severe glandular swelling, more like the Sjogren types, then you could use hydroxychloroquine or other Sjogren-aimed pharmaca. So for the vaginal symptoms, there's apparently quite a lack of studies. I found it quite shocking, actually, when preparing for this presentation. There's one paper that gives really gynecological examination information, and in this sort of small group of patients, vaginal dryness was mentioned a lot, with ulcerations and pain with intercourse, and also the narrowed vaginal opening was observed. And people mentioned a decrease in the number and intensity of orgasms, and specific systemic sclerosis-related barriers for intercourse were mentioned in skin tightness and joint contractures, reflux, and the muscle complaints. So for the vaginal and skin dryness, a lot of non-pharmacological advices are important. One of the most important one is to take pain seriously and to look for alternative interaction, because if you have pain with intercourse, it can set off a whole sort of circle of negative impact. You, of course, take time and create an optimal setting. Use water and silicone-based lubricants, moisturizers, avoid soaps and irritants. And you can take hormonal fluctuations into account. People tend to mention that the vaginal dryness is also dependent on the menstrual cycle. So that gives a direction in this hormonal influence, and it's also a reason to consider vaginal estrogen, for example, and other topical aids, and of course be aware of secondary infection, especially after antibiotic treatment. So the necessity for gynecological examination, I think, could be if there's lichen sclerosis. It's also a skin condition, which is slightly different, morphological than the sclerosis of the systemic sclerosis. But it gives itching and pain and changes in architecture. And it responds to regular topical estrogens, and especially in the early phase. So it could be really of therapeutic importance.
1 minute, please.
Yeah, to acknowledge this. So alarm symptoms are vaginal discharge and bleeding and pain and sores and in worsening, of course. So the things unsaid, I think conditions for good communication are with the health professional, the knowledge and experience and personal skills of the health professional, and uncertainty, embarrassment of patients is another barrier. We can discuss this later. So I think this is what I wanted to talk to you about. Thank you so much.
Thank you. Thank you, Dr. Anne Schouffoer. I will introduce the next speaker, Dr. Maria Grazia Lazzaroni. She is a rheumatology specialist working at the University Hospital of Grazia in Italy. She has been involved in multiple national and international research projects in the field of systemic sclerosis, including several studies within the USTAR network.
Good afternoon, and thank you for the kind introduction, and thanks for the opportunity to be here today. Today I would like to speak about an interesting project I had the chance to conduct in the last few years together with the patients in my unit. Our center is very oriented to topics like gynecological issues and reproductive issues in different autoimmune diseases. And this is because our center has a long tradition of a pregnancy clinic. So I'm lucky to say that we very much care about these aspects, and systemic sclerosis most often affect female patients. And so we decided to evaluate women's health under different aspects. And to do this, we prepared a new questionnaire that we developed together with our gynecologist and together with patients' representatives. And in this questionnaire, we had different sections. The questionnaire was very long. This is not intended to be applied in everyday practice because it takes like 30-40 minutes to be completed. But this was an exploratory part to understand what we are underestimating, what are the unmet needs of our patients. And we had the chance to evaluate the answers from 168 scleroderma women from my center who accepted to participate to fulfill this questionnaire. And here I highlighted that we had also a significant part of them who had received their diagnosis when they were still in reproductive age. And this very long questionnaire was divided into 5 sections. And as you can see here, we had also sexual dysfunction among these 5 sections. And specifically regarding sexual dysfunction, we had specific questions we created to evaluate sexual dysfunction. And also we used an already validated questionnaire, which is the Female Sexual Function Index. Sorry. And we wanted to better evaluate this aspect, and here are the results. About 50% of our patients reported a negative impact of systemic sclerosis on sexual life, and the most reported symptom was vaginal dryness, but also, as Anne was saying before, it's very important to understand that sexual life and intimacy are also affected by many other aspects of the disease, and the most frequently reported were digestive symptoms, finger ulcers, shortness of breath, and skin tightness, and also the changes of physical appearance. And looking at the other validated questionnaire, the first important information is that only 40% of our patients wanted to fulfill the questionnaire. And we also look at the reasons why they were not completing the questionnaire. And half of them answered that this topic was not relevant for their quality of life. 1/3 of them because of sexual inactivity, and a minority of them because they were ashamed to share this kind of intimate information, even if the questionnaire was anonymous. And the tendency was that patients who did not complete the questionnaire were older at disease onset and at the questionnaire completion, and more frequently in postmenopausal age, and more frequently were affected by a more severe disease with greater damage accrual. And 66% of our patients completing the questionnaire had sexual dysfunction, which is under a certain score established for this questionnaire. Again, they were more frequently older and in postmenopausal phase, emphasizing that in this phase we have also other symptoms related to menopause itself that can worsen the symptoms already present of scleroderma. And this was associated also with a longer disease duration, again with other involvement of the disease, so the presence of esophageal, lung, and heart involvement, and in general with a most severe disease and with receiving more treatments. And I would like to briefly analyze also another important aspect. I don't know if I'm quite off topic, but I do think that this is also an important part of intimacy, because again, in this case, it's a very sensitive topic, and it's very important that female patients share this kind of questions and perspective with their physician. And here we analyzed the answers from the patients in reproductive age, and half of them told us that they desired a pregnancy after diagnosis. And we are quite happy to say that 95% of them discussed this topic with their scleroderma clinicians, and they were satisfied from this counseling in the very majority of cases. And unfortunately, a significant proportion of them, 40% of them, did not satisfy their family plan, so they had a smaller family size than desired. And regarding the reasons for this, half of them were afraid of not being able to take care of their children, or they were afraid about harmful medications during pregnancy. And so these are important aspects, and again, I encourage female patients to talk about these important topics with their doctors. And finally, I would like again to stress another important topic of discussion, which is contraceptive methods. Here, the topic was under discussed for sure. 2/3 of our patients declare they have never discussed contraceptive methods with their SSC clinicians, mainly because they thought that contraception was not related to SSC or was not of interest for the rheumatologist. Half of them told us that at least they discussed it with a gynecologist, but only half of them. And my message is that contraceptive drugs have important implications in autoimmune diseases and should always be discussed with rheumatologists. So I do think that contraception, family planning, pregnancy desire should always be discussed in the context of a clinical evaluation when young female patients wish to have a family or to discuss about contraception. And now it's Cosimo's turn.
Thank you, Doctor. Thank you, Dr. Maria Grazia Lazzaroni. Now I'm introducing Dr. Cosimo Bruni. He's a rheumatology specialist doctor working as a researcher in the cystic sclerosis field at the Department of Rheumatology in Zurich, in Switzerland. In the past years, he has been involved in multiple national and international research studies in the field of systemic sclerosis, as well within the U-STAR network.
Thank you very much, Linda, for the introduction, and I'm very happy to be here today and to deliver this talk, which was actually very, very wished by FESCA. Because we are talking a lot about scleroderma, we are talking about female sexual issues, female gynecological issues, but hey, we are there as well, okay? So there are men, we are very used to have a lot of male doctors, luckily this is changing. We are used to see a lot of female patients, but there are men, so let's not forget the men. Systemic sclerosis can be different when you have a female patient or a male patient, meaning we know that the disease is quite heterogeneous, can have manifestations more frequently or less frequently. We know a lot that antibodies, so these markers that patients have in the body, are associated with certain manifestations, but we know also that a male patient and a female patient might be different from the way they manifest their systemic sclerosis. It's what we are taught in medical school when we receive our rheumatology training, is actually that having a male patient with systemic sclerosis is something that maybe should raise your level of attention, because male patients have tendency to have a bit more serious skin involvement, a bit more serious lung involvement. So certain manifestations are either more frequent in men, or they can be a bit more serious. So we have, let's say, a spotlight on a male patient when this patient is in front of us. And one of the topics that was actually already introduced is sexual issues. So this is something that all males have to deal with, but this is almost never the topic in the clinic. And there can be different issues. There might be issues when it's time to have an intercourse. There might be issue when there is desire for intimacy, and intimacy is not necessarily sexual intercourse. Intimacy is hugging each other, caressing each other, touching each other, kissing. A lot of, I would say, a big part of a relationship. And when a patient with systemic sclerosis desires intimacy, this can be as hard or as impacted as sexual intercourse as well. So there was a lot of research in the past regarding what are the implications of systemic sclerosis in male patients regarding erectile issues. And we know that many male patients with systemic sclerosis have issues in getting ready to have an intercourse with a partner, but we do not know much more about the other aspects. And among the other aspects, there is also the so-called function of the pelvic floor. So we all have muscles, and let's say from the male part is that area that goes between the penis and the anus, which are very important in order to hold your waters when you need to go to the toilet but you can't, to hold your stools when you need to do number 2 but you can't. And this part of the muscle of, let's say, the intimate area is not that much more affected in systemic sclerosis male patients compared to male individuals in the society. So that was the reason why there was a lot of focus on erectile dysfunction, a lot of questionnaires, a lot of studies showing that this is more impaired, but not that much about intimacy. And actually, I found only one study in the literature which I would like to talk to you about, and which was led by one of the previous speakers as well. So not of this session, of the previous session, which was Dr. Mike Hugh. They chose to have systemic sclerosis male patients together, and instead of using a technique, which is the questionnaire way of collecting information, so having a one-to-one interaction with the patient, they chose to bring patients together in a, let's say, small meeting, which is called focus group. Maybe some of you already participated to focus groups for other research purposes. It's a way of gathering 5 to 6 people, let's say 7 maximum together, spend 1 hour together discussing topics through the moderation of someone who is guiding the discussion, and then trying to bring up topics which maybe a single person would be ashamed to bring up, to discuss about, but another wouldn't. And that is already a good success when someone mentions a topic, in this case, for example, something related to intimacy and sexuality, and the other 5 persons are not mentioning it, but just, yes, that's an issue. So this is already a very successful thing. They had 25 men across UK and the US, and they started discussion, what is scleroderma for me? What does this bring in my life? Which are the impacts that the condition is having in my life as a man, as a husband or as a partner, and as a working person, part of the society? And exactly one of the topics that was, one of the topics that was brought up is the one which is in blue color, the impact of SSC on masculinity in general. And all that you will see in italics or between commas are actually quotations of what people said during this discussion. So these are not my words, these are words of other patients. And when the sphere of intimacy is actually touched, there were 3 main points which were raised by the patients. It impacts on what is my role as a man and my activities as a man. It impacts on sexual life, intimacy, and as we already saw, erectile dysfunction. but it also impacts on the self-image, meaning on the image that I have of myself, how I see myself as a man, again, as part of the society, and as a member of my own relationship. When the topic is actually sex, intimacy, and erectile dysfunction, the discussion that came up in the meeting was, I know that this is something which might be related to the disease itself, and therefore it's something that I should be taking care of. So patients themselves say, hey, I have an issue, I want to solve it. And this is something which, luckily, we have certain medication that can be used, which are already, let's say, used for other vascular manifestation in the disease, which might help bring the blood where it's needed, when it's needed. And this is something which, therefore, can be fixed, not always with medication. There might be some surgical approaches as well, but this is something which can be addressed and should be addressed. The second part of the intimacy relationship itself is actually the psychological consequences. Because what patients said in these focus groups is actually, I mean, if you cannot do it, if you want to do it, but you cannot do it, it simply doesn't work. It's not a choice you can make if your sexual intercourse is not starting. And all patients see that as a problem, and this brings concerns in their life with the impact this has in the relationship with the partner. Because there is the feeling that you are not playing your role as a man in your let's say, two persons relationship. And this brings a feeling of inadequateness on the patient. So I feel inadequate because I cannot be the man I want to be for my partner. And there's a third point, which was actually following these group discussions, was that there was a wish from the patients that the clinicians are bringing up the questions. So I should be the first actor asking my patients, is there any issue down there? Is there anything happening which is bothering you that we haven't discussed so far in the consultation? So I may be addressing it straightforward, I may get there through different pathways, but this is something that patients are wishing me to do. And this might bring to differences if I am a male doctor or if I am a female doctor. Because me, myself, if I need a doctor for lower part issues, I might have different perception if my doctor is a man or a woman. So what the patient actually said is that they don't care as long as this topic is addressed, but maybe they might talk about it differently. They might use word as penis, or they might call it somehow else if it's a guy-to-guy interaction. But as long as the topic is addressed, this would bring to the satisfaction of the patient. This is what came out of the discussion. And just to close, actually, I would like to bring up the study which Anne showed very quickly, and this is something similar to the questions that we were looking at the beginning. 80% plus of the patients, and this group is 40 patients, 10 men, so very similar to the audience that we had today in the room. 80% of them were not at all satisfied with the discussion of the topic they had with the rheumatologist. And the reasons could be multiple, and I listed more or less them on the right side. It could be that, the doctor should start the topic, not me. And this we said. But it could also be that, I wish this happened, but I'm not comfortable with discussing this topic. So we should a bit break the ice, as we said, and break the silence. And at the same time, there is the perception that maybe the rheumatologist does not have time, that it's not the right moment, that this is not the right place, or that there has been previous experience in the past when addressing this topic and then not getting any beneficial advice. I would thank you all for listening, and now give the word to Kim. Thank you all.
Thank you. Thank you, Cosimo. Our next speaker is Kim Fligelstone. She was diagnosed with diffuse systemic sclerosis in 1988, volunteering and working for systemic sclerosis for advocacy and support since the early 90s. I have to mention she likes food and likes to dance. The floor is yours, Kim.
What did you say? I like food and what?
You like food and dance.
Oh, and dance. I thought you said men. It's a good start, huh? Hi, hello. This is not an easy subject to talk about within the within the general public, but I think with systemic sclerosis we have so many more challenges that it's important to talk about. And this, with systemic sclerosis, my presentation has got it's not based on any evidence, or there's no validations. If you see any anything that people find to help them, I'm not recommending it, put it that way. So my slides are going to be about men and women. Originally, I wanted to present on tips that could help people to be intimate with systemic sclerosis. And I tried at home to elicit some help, and I didn't get any. And then the FESCA Secretariat very kindly sent around a questionnaire that we did, a very, not a proper questionnaire. And we had very little response, but fortunately we did get some response, and that is what I'm going to, most of this is based on. And as I said before, it's for men and women. We have different physical challenges with intimacy. However, I think you'll see that a lot of our feelings and emotions actually overlap. Oops. Sorry. So this was encouraging, I thought, because one of the questions was, have you spoken to your partner about any issues? And many people answering had, but they also felt that their issues were not resolved. So that's sad, but I found it quite encouraging that people were talking to each other about it. Whoops. I'm not very technical, I'm afraid. And also, I had a lot of help with this talk from a FESCA member, but so I'd already written it, and then somebody else wanted to give me their opinions. So I'm going to add some things that are not actually in front of you. But I'm going to go through these because tiredness is clearly difficult. Dryness, I'm going through the issues first. Pain, loss of libido, stiffness. These are all things that people put on the questions that I asked them. Impotency, shortness of breath and fibrosis, diarrhea and fecal incontinence. This happened to me when I was first diagnosed. I was 29 and I had absolutely no idea that this was anything to do with systemic sclerosis. Nobody warned me. Remember, I was 29 and, what was this going to impact on my life in the future? Then there's mobility, and I don't just mean hips and knees, the whole body, but also the hands. I mean, some people's hands are fixed and they can't use them. Luckily, mine are better now, but in the early years, they were fixed, and some people stay fixed. There's digital ulcers, which we heard about earlier, calcinosis, so you've got the pain again, but also the mobility issues. A change of appearance, people might not feel as beautiful or good looking as they had pre-systemic sclerosis. I know it's all in the body, all in the mind, but that's what some people said. And multi-medications can also be an issue for intimacy. Then we have feelings, and a lot of people said bad. helpless, insecure, frustrated, sad, guilty, and one that I'm not too familiar with called regular, but I think that was probably maybe in the translation. Maybe regular means it's okay. I don't know. So some of the comments, and these are all going to be very contradictory, but I think they're important because this is what people feel. Doctors need to know more. They're very grateful for the topic, that the topic's been raised. Then this was interesting. Several people were 60 or over, and they didn't want to reproduce, but they still wanted a healthy sex life or an intimate, to be intimate. But their doctors, whether it's, I don't know if it's their GP or their rheumatologist, but whoever was looking after them didn't think it was important because of their age, and they did think it was important. Someone else said it was an ordeal, which I could relate to at some part of my life. Another, don't miss it, think more about surviving, sex life is secondary, feel asexual, lubrication doesn't help much, didn't get referred to a specialist, as a doctor told me it was completely normal for me to feel like this. So, and also another doctor said no solution and offered me hormones. Then an add-on is, one person said that this is no longer an obstacle. Good for them. It is an obstacle, sorry, I've written it the wrong way around. This is still an obstacle, but no longer taboo. But I suspect that a lot of people here might think it's taboo. Or even maybe not here, but a lot of patients new to scleroderma. More comments. It's uncomfortable in a young couple that we still have this problem without a solution. Creams make me feel more comfortable, but I can't have sex. It's not the most important thing. When it's solved, it's because another type of practice is practiced and not the traditional act as such. Being able to speak with total freedom gives you freedom. Loss of self-esteem sometimes blocks sexuality much more than the physical difficulties. And sharing is a way of growing. Yeah, sharing is a way of growing. So what helps? And this is what is not, I'm not recommending it, I'm just saying. Lubrications such as gels, creams, and natural oils came up a lot. High hyaluronic acid. So I'm just making a note here that I don't think if your skin is cracked that it's probably a good idea to use any creams or gels. But I'm not a doctor, so maybe that's wrong. Then there's something called progesterone, which I think is a hormone. Internal vaginal ovules. Regenerative treatment with radiofrequency. 3-component penile prosthesis. Caresses and foreplay are important. And getting in the mood, I would say. Make time for yourselves to get in the mood. And that could help. So, in conclusion, there seems to be a collective feeling within all these questionnaires that came back to me that doctors are not well versed on this topic for people with systemic sclerosis. How do we move this on? And we might have some questions in a minute. Would it help if we were referred automatically to a gynecologist or a urologist if, when we're first diagnosed? That's just a question in my head. Reading the testimonies, I can see there's no one answer, but taking the time to talk and being prepared to try different approaches or to be experimental may help. As in the general population, don't be afraid to say no. And this is just the beginning, tackling intimacy in systemic sclerosis. If this subject is important to you, let your health providers know. And I'm going to pinch something from Tanya's talk, don't suffer in silence. Speaking for myself, I don't expect my scleroderma specialist to know much about this, but I would appreciate a referral to an expert. And in fact, that did happen to me, so I was lucky many years ago. Not everybody who took the time to get back to me thought this subject was important. However, we are all different, and perhaps the disease, if someone has a condition and is less active, they may change. Others were grateful that we're starting this conversation, and I felt, and felt, not me, but it's true, that it needed much more prominence. I think, hopefully, we are all living longer with systemic sclerosis. So let's have some pleasure and enjoyment and some fun for the rest of our lives with this condition. Thanks very much. I must thank Mercy. I'm not sure if you're here, but I want to thank her and the Spanish organization, because they really provided a lot of material for this condition. Sorry, there you go. And lastly, I am recommending this viewing. This is an SRUK webinar on sexual health and dysfunction. It is from 23, but I think the issues are still similar. And it's from Tanny, who gave the last talk on digital ulcers. Thank you very much for listening, and I'm going to hand over to Anna, who is going to go through some important things. Thank you. Thank you.
Thanks so much, Kimber. It was really wonderful. I think we'd like to close. Oh, I think I'm missing a slide. That's okay.
It's there, isn't it?
No.
Go back. Go back. I might have switched it on. When I left, it was on.
Oh, it was on. I'm so sorry.
Can you go back one? To the last slide of the whole presentation.
Doesn't work. Okay. No, it's okay. We just wanted to sort of discuss how to proceed. How can we improve communication? And of course, that's a very difficult question, but we've got this layered approach. I think Fesca has made a huge contribution with this session. I think that's mainly, that's good, yeah, on the patient level. So if you prepare for a visit at your doctor's, you could prepare with a sort of conversation starter to get things running in communication. Your partner support, of course, is very, very important. And you can also refer to the prevalence data, and you've heard how many people have complaints. And you could always ask for referral, as Kim mentioned. That's a very good idea. And you could also contact your doctor and email a post-visit summary of your discussion. And on a health professional level, I think this definitely needs improvement, as we've seen. So there should be tailored education for postgraduate doctors. And of course, expert centers have also a role. You can build your own network. For this session, for me, it also was the perfect opportunity to reach out to the gynecologists in my centers again and to discuss how to have a smooth communication about patient care. There's, of course, the national implementation strategies that we should all look forward to. And on a European level, I think the FESCA has played a huge role. So go FESCA, with prioritized patient-led discussions. And of course, we could discuss screening and self-management tools. And there's a lot of research to be done. So I'd like to open the discussion.
Thank you. We have some questions from the audience. So I'm going to ask, or does anybody now has an urgent question? Just raise your hands. Otherwise, I'm going to read it. There was one question, are there any sexual health counseling services or psychological support options specifically for men living with chronic illnesses like scleroderma? Maybe Cosimo can answer that.
So that's a very relevant topic. At least if I can think what was my clinical life in Italy, there was not a specifically dedicated sexual service for men. There was a sexual issue, let's say, multi-clinic, and this was combining gynecologists, urologists, endocrinologists, and psychologists, which were actually providing advice on demand. So there was not a package which was, let's say, available for everybody, everything, but it was more trying to investigate if there was any other cause which was not necessarily scleroderma as the reason for the sexual issue or the sexual impairment, because yes, scleroderma can be a main cause, but it's not the only, because there is general population issues which might happen as well. And then we're receiving the proper, let's say, care if anything, let's say, not rheumatological was identified. From a, let's say, specific male perspective, yeah, jein, as they say in Germany, in Switzerland, sorry, but not really. And I would also like to link it to one of the questions or one of the comments, like being referred directly to a urologist in that case may or may not be helpful according to how much do they know about scleroderma. Because if a urologist is treating a man as a man without scleroderma, the effect of the medication, the effect of the approaches, and the kind of approach which is chosen may not function the same way. And this might cause even more frustration. Because if the specialist is not helping, then who should be helping? Yes. So it's something which should be combining specialist opinions at the same time. Okay. And then trying to personalize the approach to the person, not just to male and female, but to the PWS, person with scleroderma. Okay.
I have some new questions rising a lot. Is erectile dysfunction a direct result of scleroderma, or more likely a side effect of vascular damage, medications, or psychological stress? I don't know who's going to answer it. Maybe you can, Cosimo? I can, but I'm happy to... Or Dr. Anne Schouffoer, maybe? Go ahead.
Very good question. The cause, as I said before when I was making the example of the urologist, there might be different reasons why the erection is not happening. It might be the lack of libido, and this has something to do with scleroderma, but can be also the cause of, the consequence of psychological stress in life, of other things going on at the same time. And in that, yes, scleroderma will play its part, but would be not the only cause. Then there can be hormonal issues, because if a man is lacking testosterone, and this has not been proven to be scleroderma related so far, the erection might be a problem again. So this is where the endocrinology or the urology department would play a major role in identifying if there is a testosterone deficiency, so the sexual hormone of men, and that which can be replaced. Can be replaced with ointments, can be replaced with tablets, with injections. There are multiple supplement ways. And the disease itself can then impair the way the blood gets to the area and can impair the elasticity of the skin of the penis. So that is also an issue. And if the urologist doesn't know that and gives you the tablet to bring the blood, then the blood doesn't get there anyway, or it gets stuck. So this can be an issue which maybe can be helped with some surgical incision, helping the skin to be not more elastic, but at least more prone to expand.
So who would know about that?
What's in the mic?
That would be a urologist who deals with sexual issues and who is in good contact with rheumatologists. So I wouldn't refer a patient to a urologist without an accompanying letter explaining the whole things and giving availability for consultation with me for any doubt before just, hey, take the tablet. That's not the way it works. Or
Okay.
it should.
We have, oh, sorry.
I think it's really important, of course, this network indeed, that you have the communication with the gynecologist and the urologist for background information.
Yes.
And I think for females, it's also quite difficult to say about vaginal symptoms. We have this fluid, it's not the glands, it's more transudate, we call it. So it's different than the glands that I showed you for the saliva. And I'm quite shocked, actually, and how little knowledge there is about vaginal symptoms from a mechanism point of view. So I think there's a lot to be done there.
Okay,
Yeah.
okay. I think this question is a little bit related to your answer, because there was one, I have time for one question. Is there any role for local hormonal treatments to reduce dryness in menopausal women problems? Maybe Dr. Maria can answer or react to that?
Can you repeat the question? Sorry.
Is there any role for local hormonal treatments to reduce dryness?
Maybe Jan can answer.
Yeah, well, I think the gynecologists that I've spoken do agree that this is something that might alleviate symptoms.
Yes.
And of course, there's worry about side effects and risks. But I think the benefit prevails here, but of course always in the direct communication with the gynecologist. And as I explained about the Sclerosis, which is also quite important to diagnose, because this does really have a local effect, hormonal treatment,
Okay.
on the development of strictures.
Okay, thank you. Thank you for being here. It's not an easy topic to talk about. Sorry? No. It's,
Okay.
sorry. This is the last session for today. I have to mention that only for those who registered in advance, there is tonight a patient dinner at 7 in the Hotel Stratos Vasilikos. And tomorrow the first session will be at 9 a.m. at the banking hall, navigating gastrointestinal complications. So have a good evening until tomorrow, 9 o'clock. Thank you.